Go ahead, Dr. Arnold.
Good morning. I'm glad that you all have joined us. I've been asked to introduce Dr. Burns, a member of our division, and he is one of our own. Not only does he come from the University of Louisville, but he contributes to the university as well as the community. So I want to tell you, the former governor of Alabama said that stressful times don't create healthcare heroes, they reveal them. And Dr. Burns is one of those people. So that now that everyone knows what I already knew, that Dr. Burns is very valuable, he has stepped up in these times of the pandemic to help out the division with the retirement of our former chief. He has taken on the responsibilities of the VA nearly single-handedly. He does the hospital epidemiology, antimicrobial stewardship, the inpatient and outpatient services, as well as the e-consults, which is no small matter. He is also essentially the face of the division, as you've probably seen him on the news many times as of late. So at this time, I want to turn things over to Dr. Burns as we look forward to hearing from him. Thank you.
Thank you very much, Dr. Arnold. Thank you for those kind words. And I'd like to thank all the faculty and staff for, again, another opportunity to present. Again, as far as my knowledge goes, it increases because of what you continue to teach me. Today we're going to be talking about the outpatient management of COVID-19. And I think I'm having just, okay, there we go. I want to go ahead and first indicate I have no disclosures. Some objectives from today's talk. We're going to review COVID pathophysiology, just a little bit of that. Also, we're going to review vaccine options. We're going to discuss antiviral treatment options, and we're going to finish up discussing the Omicron variant. Before we get started, I just want to mention that COVID-19 has been a very, very difficult disease to deal with. Our pandemic still persists. I gave a talk a little over a year or so ago on the topic of COVID-19, and I was hoping that we would have it behind us, but as we all know, it's affected each and every one of us in some way, shape, form, or fashion. So we're going to start off with a case. The case C is a 62-year-old gentleman, a history of hypertension and type 2 diabetes mellitus, who presented to his primary care provider with a fever, cough, and mild fatigue. He says the symptoms began 3 days prior to his presentation for this evaluation. He denied at that time having shortness of breath, chest pain, or productive cough, but did note that he was not able to smell the pepper he was putting on his food. He does admit to recent sick contact with his 25-year-old son, who was recently diagnosed with COVID-19 days ago, and he was complaining of similar symptoms. On physical exam, he was awake and alert. His temp was 100.1, pulse was 95, respiration is 18, blood pressure 155/89. His oxygen saturation on room air was 95% when it was checked. He weighs 290 pounds, is about 5 feet 10 inches tall, and has a BMI of 39. Except for faint wheezing throughout his lungs, the remainder of his exam was pretty much unremarkable. As far as his labs and x-rays, his chest x-ray was read as no acute disease, and his labs were unremarkable except for a positive Rt Pcr Test. He was then diagnosed as having mild to moderate COVID-19. Question from this case is, what would be the next step? Chances are this patient would not be admitted to the hospital and would likely be managed as an outpatient. COVID-19, as I said before, has been a very, very difficult disease to deal with. Most recently, we've had over 900,000 deaths here in the U.S. as a result of COVID-19. There's been a total of 76 million cases this entire time. And again, this is alone here in the United States. want to review real briefly the history of COVID-19, and I've sort of presented this same information at our last talk, but again, I just want to kind of briefly go over it. Before 2019, we did have coronaviruses that were present. The first ones were discovered back in the 1960s. And then even in the early 2000s, we had some new coronaviruses that were discovered. These were human coronaviruses. The first of these novel coronaviruses, which are sort of what I call mutant viruses, that take in consideration coronaviruses from a human and coronaviruses from an animal. The first of this sort of hybrid sort of showed up in the early 2002 time. It was at that time called severe acute respiratory syndrome, or SARS. About 10 years or so later, another one showed up in the Middle East. It was called Middle Eastern Respiratory Syndrome, or MERS. And as the name indicated, it was primarily within the Middle East. Presently, this SARS-CoV-2 is a third outbreak of this sort of novel type coronavirus, we're presently continuing to learn more about this, and it persists through today. Again, briefly, as far as the history goes, this particular coronavirus was initially discovered in Wuhan, China. It was believed to have been associated with wet markets and animal markets there in China. The virus was there. We were trying to figure out what our intermediate source was, because generally these viruses, they do have a reservoir. It goes from a reservoir to an intermediate host, and then from an intermediate host into humans. So again, we still haven't totally got it figured out. We don't have the beginnings quite figured out yet either. That investigation is ongoing. With regards to the epidemiology, it is believed that the reservoir for this, and as for the previous coronaviruses, was a bat, were the bats. And then, as I mentioned, it goes from the bats to an intermediate host, and then to a human being. Initially, the intermediate host from the first SARS was believed to have been the civet cat. For MERS, that intermediate host was suspected to be camels. And presently, this SARS-CoV-2 right now is suspected to be the pangolin. But again, those studies to figure out the intermediate host are still somewhat ongoing. Now, when we talk about the pathophysiology, again, here's a slide I presented at my first talk. This electron microscopic view of the actual coronavirus. And you'll notice, particularly on the right, if you look closely, you see those projections coming out. Those are the so-called crowns, or what we know as the spike proteins that are present. Now, when you talk about the life cycle of the coronavirus, it has four basic premises that it follows. It will attach, it penetrates, it takes over machinery within our cells to reinvent itself, and then these new particles get released out into circulation to go on to affect other cells. Now, more specifically, and we'll kind of walk through this just a little bit slower, the human coronavirus, this SARS-CoV-2 virus, is an RNA virus. It's an RNA virus that is within a nucleocapsid, that is within a membrane, that is within an envelope. And on top of all this are the spike proteins. Spike proteins that are present there, they interact with receptors on our cells. These receptors are known as the ACE2 angiotensin converting enzyme receptors that are on our cells. There are other smaller interactions that do occur, but this is the major one that allows the actual virus to gain entry into our cells. Once this goes into our cells, the the previous proteins that I've mentioned, particularly the membrane protein and the nuclear capsid protein, which is surrounding the actual viral RNA, all those layers disintegrate, and then what you have left is the release of the viral RNA that is within the center of the virion. Once inside, it sort of hijacks our materials inside our cells to reproduce itself. So the viral RNA actually goes to our ribosome and starts transcribing its proteins. The very first protein that gets transcribed by this is called an RNA-dependent RNA polymerase. From there, this viral RNA-dependent RNA polymerase goes on to replicate other types of structural proteins and non-structural proteins. The non-structural proteins are the actual RNA itself that's going to be eventually packaged and sent to other cells. The structural proteins that get synthesized are the nuclear capsid proteins that will surround the RNA, along with membrane proteins, which will line the actual nucleic capsid itself. And then you have the envelope proteins, which will surround the entire virion with spike proteins attached. Once these start getting transcribed, it will be translated. The nuclear proteins and the nucleic capsid proteins along with the RNA, they get packaged out in the cytoplasm. The other proteins actually go to other parts of our cell, the endoplasmic reticulum, and then eventually to the Golgi complex. And from there, it gets acted upon and sort of get packaged and reassembled, if you will. Also, there are other viral proteases that are present that the coronavirus has. It allows for cleavage of some of the precursor proteins to allow the actual virion to fully mature and to increase its infectiousness. By the time we have the mature virion that has formed, it actually buds out of that cell and goes on to infect other cells. And this is sort of an assembly line, if you will, where it just continues on and just goes on to infect other cells, and for other beyond those cells to get infected. Now, while this process is taking place, some of the damage that does occur, and as the virus penetrates into our cell, and as those mature virions leave the cells, they damage those cells, and the damage that does take place initiates the inflammatory response. In the inflammatory response, cytokines and other inflammatory molecules such as the TNF alpha, the interleukin 1, interleukin 6, and 8 chemokines and cytokines are released. This allows for that inflammatory process to proceed, and it calls for monocytes, neutrophils, and other macrophages to come to release their chemokines and cytokines. And all this, if it takes place in the lung, will be within that alveolar, allows these things to occur within that alveolar space. Again, this is what goes on when we actually breathe in the particles and it settles in our lungs. Now, the problem is that this response becomes dysregulated, and the permeability that allows for the inflammatory cells to come in, the permeability does not shut off, if you will. We get increased amounts of fluid present, which leads to pulmonary edema. We get ventral hyaline membrane formation, and the changes that eventually occur are similar to those that you see in ARDS. In addition, there is activation of coagulation systems, which allow for microthrombi to be formed. And this whole process where the inflammatory response gets turned on but really can't get turned off is known as the cytokine storm. all these changes do lead to some of the symptoms that occur when somebody gets infected with SARS-CoV-2. And as I mentioned, sort of anecdotally, if you will, the ACE2 receptors they are present in other locations. They're present also in the brain, the heart, the liver, ileum, and our kidneys, along with being present within the lungs. When these reactions occur in those other places, you can see things like elevated bilirubin, you can see cardiac injury. Some patients may present with congestive heart failure and elevated troponins, along with dysrhythmias. In addition, acute kidney injuries and neurologic complications can occur. Again, this is all the result of this initial infection. Here's an illustration I presented last time as well too. Again, now this is when the reaction takes place in the lungs. You have the type 1 and type 2 pneumocytes. The type 2 pneumocytes get infected. They eventually start releasing more virus particles, and then they go on to infect other lung cells. And in the meantime, we have that inflammatory response that I mentioned going on, and with the TNF alpha and interleukins being released, calling for more inflammatory cells to help fight this battle against the virus. And again, this is the dysregulation part of it, where we get the pulmonary edema, the hyaline membrane formation, and the activation of our coagulation system, that leads to the formation of microthrombus, pulmonary emboli, and the other things. Now, when we talk about transmission, that how the person acquires it, it is primarily acquired through respiratory droplets that actually get inhaled. Those droplets are usually expelled from an infectious person when they talk, sneeze, cough, and I mentioned even singing. Any kind of exhaling or projection of those particles can occur. Now, just real briefly, the inhalation of those fine respiratory droplets allow for the inhalation of those particles, and as I mentioned, that's how it's primarily obtained. Now, it can also be obtained through direct touch, through the virus particles landing on the surface. If a person contaminates their hands, for example, and can touch areas where you have exposed mucous membranes, such as in the eyes, the nose, or the mouth, or if we get direct splashes or sprays, this can actually also cause transmission of SARS-CoV-2. But by and large, the vast majority of transmission is occurred through inhalation of the respiratory droplet. And again, to reemphasize the fact that we have what's called fomites, which are basically the deposition of those infected particles on the surface. That transmission can occur. Again, it is low compared to the airborne transmission, but it is possible to occur in this way. Again, when we talk about, and I'll get later on when we talk about mitigating measures, that's why it's important to wash your hands. Okay, these people usually present the symptoms that are usually seen with these patients. They usually present with fever, cough, and shortness of breath. I've broken down the actual symptoms and percentage of COVID-19 patients that present with these types of symptoms. There are some people that do present with fever alone, some with cough alone, but other symptoms that can occur, runny nose, sore throat, headache, abdominal pain, even diarrhea. And of course, the big one I believe everybody is familiar with is the loss of taste and smell. Okay, what about testing? Well, when we talk about testing for COVID-19, the two most popular tests are going to be the gold standard test, the Rt Pcr test. And the other test that we utilize is called an antigen test. Now, there is an antibody test, but the antibody test, just so you know, we really don't use that. We really don't have any reference. I haven't seen any literature for a reference on what to do with the actual numbers for that. Plus, the other thing too is it just measures antibodies that have formed as a result of a coronavirus. Maybe a human coronavirus, or it could be something like SARS-CoV-2. But again, we don't have a really good reference for that. So the two major tests that we utilize are the Rt Pcr test and the antigen test. The Rt Pcr tests are, as I mentioned, the gold standard. It actually measures nuclear material from the actual virus. The antigen test, however, measures more of the proteins that might be present. There are advantages and disadvantages to both. The advantage to the RT-PCR test, as I mentioned, it does measure actual RNA, the nucleic acid from the virus. The disadvantage is, however, the test is usually, it takes a long time to get the result back. The antigen test, of course, again, the downside of that is the fact that you can have a lot of false negative testing. But the advantage of the antigen test is that you do get the results back relatively quickly. Now, when a person does test positive, what do you initially tell them to do? Well, they're initially advised to stay home. CDC has recently changed guidance on this, and I'll just sort of briefly go over it. Where you can, if you do test positive, then you would isolate. The isolation period is supposed to be for 10 days. If you don't test positive, or let's say you come in contact with someone and someone who's unvaccinated, for example, then those people are encouraged to quarantine. But the bottom line is, for the first 5 days, no matter of your vaccine status, you do need to be separated from people. The first 5 days, you should be wearing a mask. And after the fifth day, if you're feeling better, you can go out from your isolation/quarantine, but you still have to wear a mask for the remaining 5 days. Again, this is part of the updated isolation guidance given by the CDC. And one other thing to inform people, when it comes to time to seek emergency attention, people that may have symptoms such as trouble breathing, persistent pain in the chest, confusion, an inability to stay awake, or they start having changes in their lips or their face, they become blue, then those people are advised to call 911 and proceed to their local emergency. So, what about treatments? And this is going to be probably the most important part of this lecture. This is the all new parts. We looked at the NIH guidelines, and I'm going to be concentrating primarily on the patients who do not require hospitalization or supplemental oxygen. These guidelines are also present, as I mentioned previously. They are mentioned on the NIH, are available on the NIH website for anybody who wants to refer to those. And again, this is they do have guidance for people who are discharged from the hospital and people who are discharged from an emergency room, but find that they do have a need for supplemental oxygen. Again, these are available on the NIH. So, one thing that's very important, especially when you're dealing with people who are newly diagnosed with COVID-19, you want to find out if they have any other, what we call comorbidities, or anything that will put them at risk for severe illness, being infected with COVID-19. Some of those things that will put them at higher risk are people who have cancer, chronic kidney disease, chronic obstructive pulmonary disease, any type of heart problem, someone who's in an immunocompromised state, someone who is obese, pregnancy, along with sickle cell disease, smoking, and diabetes will put you at risk for severe illness uh, if you were to acquire COVID-19. Now, some of the treatments that are available. First, we have treatments of mild to moderate COVID-19. If you are, let's say, not admitted to the hospital to be treated in an outpatient setting, treatment for mild to moderate COVID-19 within 10 days of symptom onset, monoclonal antibodies can be used. Monoclonal antibodies themselves are proteins that mimic our immune system, their ability to fight off different antigens such as viruses. Presently, the only monoclonal antibody that is active against our SARS-CoV-2 variant that is in high supply is the Omicron variant. Only sotrovimab works against that. We did have two other monoclonal antibodies, the Regeneron 2, along with the bamlanivimab, etesevimab, but it's been shown that those are not effective against the Omicron variant. So in this particular case, with Omicron being the primary variant that is prevalent here, only sotrovimab can be used with regards to monoclonal antibody usage. Now, there is another combination monoclonal antibody, the tacrolimus and silgavimab, that has a special indication, not really used for acute treatment, and I'll get more into that in just a few moments. First, monoclonal antibodies, you see, they work primarily by blocking cell uptake and also by blocking cell membrane fusion. In addition, they also try to bind up the spike protein, which decreases its effectiveness. And that's primarily how the monoclonal antibodies work. Now, the monoclonal antibody sotrovimab, it is given under emergency use authorization. However, it is still an investigational drug. It's indicated for patients who are 12 years old or greater, and it was approved for emergency use authorization back on May 26th of last year. Again, it is a recombinant human IgG monoclonal antibody that binds a particular epitope on the spike protein and decreases its binding to our ACE2 receptor cells. That's the believed mechanism, but the exact mechanism at this point is still pretty much unknown. But it does appear to prevent the fusion of the actual virus and binding of the virus to the ACE2 receptor. As I just mentioned, the Omicron variant has become the predominant variant in this area, and it's shown to have markedly reduced susceptibility to the two other monoclonal antibodies that I mentioned. And because of that, those two monoclonal antibodies do not work against this Omicron variant. Now, there is one other treatment. This was actually from the article in the New England Journal of Medicine recently. And remdesivir, which is our antiviral that has been previously approved for treatment of COVID-19. Its use was actually expanded by the FDA to be used as a treatment for non-hospitalized patients. That was done on January 21st of this year. Remdesivir itself was originally developed to treat the Ebola virus. It actually acts as a nucleoside analog or a nucleoside pretender. And it actually gets incorporated into the reproduced RNA of the virion that's being produced. But once it's, as I said, it's sort of a pretender, it's a false base, if you will. And once that the virus realizes that this is a false base, it does what's called a chain termination. It stops making virus and essentially renders the virus inactive. Now, again, for this particular use, remdesivir can be used for the non-hospitalized patients. The symptoms that occur with COVID-19, the remdesivir can be used if it's given within 7 days of that symptom onset. Again, it is for treatment of the non-hospitalized patient diagnosed with mild to moderate COVID-19, but who may be at risk for progression of severe COVID-19. The dose that's given, and of course this is a lookup, but I will mention, it is a initial 200 milligram dose. The downside of this, and the reason I've been told that it's not really favorably looked at, is that the patients have to come back to their setting, whether it be an emergency room or an infusion center, have to come back 2 more days to get infusions. So it's really a 3-day process. But again, this is a tool in our toolbox that can be used. This is just an illustration, again, real briefly, of what happens. Spike proteins bind to the ACE2 receptors. It gets taken up into the cell. The RNA-dependent RNA polymerase gets produced, and it starts producing viral RNA, which eventually produces the viral protein. Now, we have something like remdesivir that's given. Remdesivir, once it actually gets into the cell, it becomes its active form, which is called the GS441524. That gets incorporated. It's actually taken up by the RNA-dependent RNA polymerase and gets incorporated into this new viral RNA that's being produced. The viral protein, as a result of having this false base, goes away, the chain gets terminated, and this virus just gets destroyed and does not progress any further. Again, that's the action of remdesivir. The new, good, and exciting news on our fronts are the introduction of antiviral therapy, the oral antiviral therapy, which is believed in, and I truly have said this, that this would actually be a true game changer when it comes to outpatient treatment. The first of these was Maliparavir. Maliparavir is an oral antiviral drug manufactured by Merck. It is also a nucleoside analog, okay, a false base, if you will, nucleoside analog. And it eventually inhibits SARS-CoV-2 by pretty much the same sort of mechanism as the remdesivir. That is, it gets incorporated. And once it's incorporated, the actual virion particle becomes unstable and undergoes what we call viral mutagenesis. Now, Maliparavir, according to the company, was reported to have reduced admission and hospital death by around 50%. It was given emergency use authorization approval back on December 23rd of last year, and it's given for patients 18 years and older. It's indicated for adults who have positive results of SARS-CoV-2 testing and those who are at high risk for progressing to severe SARS-CoV-19, including hospitalization and death. As I mentioned briefly, Maliparavir, another nucleoside analog, combines with RNA-dependent RNA polymerase. The RNA-dependent RNA polymerase sees this as being either cytosine or uracil. It actually gets copied into the actual virion, as I mentioned before. There's also a proofreader that's within the viral RNA. It's called 3,5-exoribonuclease. Again, it's sort of a proofreader. The great thing about Maliparavir is that it gets by both the actual RNA polymerase. It gets incorporated and gets by other mechanisms to ensure that you have accurate bases. particularly this proofreader, so it allows for it to get incorporated. And then, as I mentioned, the RNA product becomes mutated, and it's actually a lethal mutation, and it does lead to the mutagenesis and eventual destruction of the virion. Here's another illustration of that. We have, in this particular case, we have a Maliparavir gets incorporated into the viral RNA. The RNA becomes mutated, and then it eventually gets destroyed and does not progress. Now, Maliparavir, again, its use was not recommended for people who were hospitalized, nor was it recommended for pregnant persons. The company put out a statement essentially saying that it's not authorized for patients under the age of 18. It's also not authorized for the initiation of treatment of those requiring hospitalization. It's not authorized to be used for more than 5 consecutive days, and it's not to be given as pre or post-exposure prophylaxis prevention. Again, this information is look up, but I just wanted to mention it. It's 800 milligram tablets. It's usually 4 200 milligram tablets that are given every 12 hours, and it's given for 5 days. Once again, I want to emphasize that it's not recommended for the use in pregnancy, and it's also not authorized for patients under the age of 18. When they did the studies, also, just to mention, pregnant persons were not included in the study, nor were there people under the age of 18 included in the study, which are actually the major reasons why they're not recommended for those individuals. Another oral antiviral drug that has been approved is called Paxlobin. Paxlobin or Paxlobin is an oral antiviral drug. It's a combination. It has 2 protease inhibitors. It has the one protease inhibitor, nirmatrelvir, along with ritonavir, which is an old friend of ours, used in previous HIV medications. Paxlobin, according to the company, was found to reduce hospitalization and death by 89% compared to placebo in non-hospitalized patients. It was approved on December 20th of last year, and it's been approved for the treatment of patients 12 years of age or older. Now, the treatment with Paxlobin, just sort of go through the active form of that, the PF07321332. That actually is a protease. It's a protease inhibitor, and inhibits a 3C protease. If you remember when I mentioned about the virion being packaged before it buds off to go to infect other cells, there are proteases associated with that. That those proteases would cleave off precursor proteins and allow for the full mature virion to increase its maturity and infectiousness. That's what the proteases for the RNA does. In this particular case, we have a protease inhibitor, something to inhibit those proteases from acting. So, needless to say, those proteases do, or should I say, those viral particles, those mature viruses themselves don't actually get full cleavage of the precursor proteins, and that will affect its infectiousness. And in those particular cases, those aren't able to perform their activity of going to infect other cells. Now, the ritonavir just acts basically as a booster to slow down the metabolism of it, and it does this by blocking cytochrome P450 in the liver. Now, some things you have to consider when you give Paxlobin is that it could cause severe or life-threatening interactions with certain medications. You have to use it in caution with people who are on statins, anticoagulants, people who are on medicines for pulmonary hypertension or erectile dysfunction, and even some antidepressants. The FDA does not recommend the use of Paxlobin for people who have severe kidney or liver disease. Also, you should be aware that some anticonvulsant medications can boost liver actions, which will increase the metabolism of this drug, and thus lower the actual levels of Paxlobin that would be present. In addition, even an over-the-counter herbal supplement like St. John's wort can lower the amount of Paxlobin that would be present. So if you're going to use that, make sure your patients aren't taking that supplement. It must be given within the first 5 days of symptoms. There's a total of 30 pills, but you take 3 of them at a time, and you take them twice daily for 5 days. And it's hopeful that before giving it, that all the medicines are reviewed to make sure it can be given safely. As I've sort of previously mentioned, you want to be careful with people with renal failure who can take Paxlobin. You have to look at their creatinine clearance. If their creatinine clearance is less than 60 but greater than 30, you have to reduce the dose. And if their creatinine clearance is less than 30, then it's really not recommended, nor is it recommended for people with hepatic impairment. These slides are just sort of summary slides, if you will, to sort of show exactly where these oral antivirals act, along with something like the one that's given IV remdesivir. And again, as I mentioned before, if you look closely, the nucleoside analogs, both remdesivir and Maliparavir, are going to react when forming of the new RNA. And then the protease inhibitor, the Paxlobin, reacts right here, and it blocks the formation of the proteases that are used to help precursor proteins align for full maturity and infectiousness of the newly formed particles. And again, these are just slides that just sort of highlight what I basically just mentioned. Again, these are the points where they react. Okay, EvoShield that I've mentioned before. This one, this particular monoclonal antibody is a little bit different, and the indications are different as well too. The EvoShield consists of 2 monoclonal antibodies, the Taxagivimab and the Silagavimab. It was authorized for emergency use authorization back on December 8th of last year. Its indications: this is the monoclonal antibody that's given as pre-exposure prophylaxis for certain adults who can possibly obtain COVID-19 and have a bad outcome. It's a drug from AstraZeneca. It cannot be used with people who are currently infected with the SARS-CoV-2 virus, or even if they've been recently exposed to an individual who's had SARS-CoV-2. In addition, another indication for this is for people who have severely compromised immune systems, who are not able to generate an adequate immune response when given COVID vaccines. And another indication for this, let's say persons who have had severe reactions to COVID-19, the COVID-19 vaccines. If you had a severe reaction to the COVID-19 vaccine, or you're allergic to a component of one or more things within the COVID-19 vaccines, then this medication is actually recommended for the use in these folks. Okay. It's given as 2 separate injections, and as I said, it is contraindicated in people who've had hypersensitivity reactions to the actual components within this within this drug. Those are cases that you would not want to give it. That is, if it's indicated, but you know that they're allergic to something that may be within the Evishield, then you would not want to give the Evishield to them. And some of the precautions, again, hypersensitivity, clinically significant bleeding disorders, or cardiovascular events. They noted that a higher proportion of people who had received it versus placebo did report myocardial infarction or heart failure. Yeah, very briefly, what about the vaccines? Just want to briefly mention. When we talk about vaccines, we try to encourage our patients to take vaccinations. This I got from the CDC and talked about vaccinations, and we talked about the rates of death, and we talked about weekly averages, and the information basically from the CDC said essentially that if you're unvaccinated, they looked at the death rate. This is back in December 4th of last year. They noted that the death rate was 9.7 per 100,000, and those were in people who were unvaccinated. They also noted that the death rate was only 0.7 in people who received only the primary series, and death rates of people who were boosted was only 0.1%. So they went on to conclude that if you're unvaccinated, compared to people who only received a primary series vaccine, you're actually 14 times more likely to die if you're unvaccinated versus having the primary series. In addition, they concluded that you are more than 97 times more likely to die if you're unvaccinated versus somebody who was vaccinated and boosted. So again, this for me is very compelling evidence for being vaccinated. Now, when we talk about the vaccines, I think most all of us are familiar with the present vaccines. We have the Pfizer vaccine, which has actually been the first vaccine to receive full FDA approval. That was done back in August of this year. And there's an emergency use authorization approval for ages 5 to 15. People who are age 12 and older can get boosters with Pfizer, and only adults 18 and older are able to mix and match their vaccine boosters. Moderna was recently approved this year, fully approved by the FDA for vaccination, and it is, again, as far as its indications, it's for adults 18 years of age and older. And with regards to boosters, anyone who is over the age of 18 and it's been 5 months since their second shot, they can have a booster. Again, boosters can be mixed or matched. Johnson & Johnson, the other vaccine that's been given, that is being used, is still under emergency use authorization. It's a one-shot vaccine. Its mechanism is actually different. It's actually given through with a virus vector, the adenovirus. It's given as one shot, and people can be boosted after 2 months following their one shot. The the precautions that you have to consider. I'm sure everyone remembers there were warnings given about Guillain-Barré, and along with the thrombocytopenic syndrome, warnings were given. It was initially paused on April 13th of last year, but after review of the data, it was actually reinstituted and could be resumed being administered after April 30th of last year. One vaccine I want to talk about real briefly is the Novovax vaccine. This Novovax is actually, they are submitting their application for emergency use authorization. This Novovax vaccine is actually a little different from the other vaccines that I've just mentioned. The Novovax vaccine actually uses proteins that are made, that is spike proteins that are manufactured and actually given to a person so they can have an antigenic response and develop antibodies. I'll just go real briefly. What happens is the code for spike proteins actually taken from the original coronavirus are taken out, and the genes to make those spike proteins are actually injected into a baculovirus, which is an insect virus. The baculovirus takes the baculovirus itself is injected into a moth, and the moth, the virus, once it's in the moth, the virus helps generate just spike proteins only. Those spike proteins are then harvested by the researchers and attached to nanoparticles. These nanoparticles are combined with tree bark, which is given actually to encourage an immune response. And this is injected as the vaccine, allowing for a person to generate antibodies against it. Again, Novavax is in the process of being reviewed for emergency use authorization. So you'll be hearing more about this in the near future. Just want to talk real briefly about variants. Their classifications. The variants were initially named by the phylogenetic assignment named Global Outbreak System, or the PANGO system. That's the lineages were the B117, B11529, etc. The World Health Organization decided to designate the Greek alphabet for those particular variants. According to the CDC, there's classifications. You have variants being monitored versus variants of interest, followed by variants of concern, and then variants of high concern. In the few minutes that we have left, I just want to talk real briefly about the Omicron variant, since it is the predominant variant that is within our community. Real briefly, the Omicron variant, these are spike proteins from the Delta variant and the Omicron. The areas in red that you see are mutations that have occurred. And these are mutations from the original, the wild type virus. You had a few mutations in the spike protein from Delta, but as you can see, there's a lot more mutations. And if you look at this particular area here, this area is known as the receptor binding domain. This is the business end, if you will, of this virus. Spike protein, this is what attaches to the H2 receptors. Because you have a high number of mutations here, you have about 30 out of 50 total mutations occurring in this particular area. And this is why the two monoclonal antibodies I mentioned previously, the bamlanivimab, etesevimab, along with the Regeneron 2, this is why they do not work. Omicron variant was recently reported first in Botswana on November 11th, and then November 14th in South Africa. The World Health Organization was alerted to this on November 24th, and by November 26th, it named it as the B11529 PANGO lineage, Omicron from the World Health Organization lineage on November 26th. The CDC designates this now as a variant of concern. First confirmed case in the U.S. was on December 1st. Genome sequencing at the University of California through San Francisco is where it was identified. And it's recently been, they know the recent data from South Africa and Botswana that even though it is more contagious, its infectiousness was somewhat in question. As I mentioned before, because of the mutations that have taken place, those monoclonal antibodies don't work particularly against it. And just know that Omicron, because it is so much more infectious, breakthrough infections can occur. But encouraging people to be fully vaccinated and boosted has been shown to be effective against severe illness, hospitalizations. But I believe I'm going to stop here and leave the remaining few minutes for questions if anyone has it.
That was outstanding, Dr. Burns. Thank you so much. And I know Dr. Arnold, I know you like to lead off here.
Sure. Dr. Burns, I'd just like you to share which of all those new medications are available at the VA, if any.
Well, sure, certainly. I recently checked at the VA, Sotrovimab is available. And most recently, we did get Paxlobin and Maliparavir. Those are also available at the VA. Now, they are in short supply, but they are available at the VA.
Thank you.
All right. So we got time for just a couple. If you would like, you can unmute your mic and ask a question, or if you want to post it in the chat area, we can see it there and read it for Dr. Burns.
Thank you so much. This is Dr. Aldous from ID. I have a question for Dr. Burns. Would you please clarify what the difference between the third dose and the booster?
Okay. It's been shown that people who are immunosuppressed, it's been recommended by the CDC that they receive an additional dose of the vaccine that they're getting, and we're talking primarily about mRNA type vaccines. I think it's easy to best call it a primary series and then a booster. The people who are somewhat immunosuppressed, they actually get a third shot in their primary series. It's going to be the same dosage of what they had gotten previously, whether it be Moderna or Pfizer. The booster shot is usually a lower dose, but it's given, again, a few months after the last shot, and hence the word booster. You get boosting of the immune system. Because it's been shown that those antibody levels tend to wane over time. It's been shown about 6 months is about the mark where they're low enough where you would have an increased number of breakthrough infections. The CDC has mentioned that you can give booster after 5 months from the last shot. And just so you know, right now I think discussion is ongoing, and it sounds as though the CDC may end up recommending for those people who are immunosuppressed, who have gotten the extra shot in their primary series, their boosters, they may be eligible to get their boosters after about 3 months. That's not official yet, but that's being talked about from the CDC.
Thank you, sir.
All right, Dr. Burns, a couple of questions from the chat area. One from Dr. Jeff Cowlin. He wants to know, when should we as physicians be getting a fourth shot?
Well, that actually they had talked about that in one of the coronavirus briefings the other day. There's been no exact information given, no exact guidance on that particular point given as of yet. I believe it's something in process. You sort of have to kind of stay tuned to see. But as we get out, further from our last shot, provided you got the booster shot, then that is going to be a consideration. Right now, there's nothing official from the CDC with regards to a statement regarding a fourth shot, or maybe, for lack of a better term, a second booster.
All right, a question from Dr. Philip May, one of our community doctors, wants to know what are the major risk factors for poor outcome from COVID-19 infection?
Okay, I actually showed that on one of the slides. Those people that have comorbid conditions, those people that may have high blood pressure, those that may be obese, pregnant women, chronic kidney disease. These are just to name a few. But suffice it to say that that people that have comorbid conditions and they're over the age of 55, usually if they were to get COVID, they're more likely to have severe COVID and possibly a bad outcome.
And one last one. This is from Dr. Stanley Levinson. He says, Dr. Burns, thank you for your clinical work. We used to work together at the VA hospital when I was the lab director, and he's glad to see you. Real quick, let me scroll back up here real quick. He said I would like to point out, as you know, that it's important for doctors to understand the Rt Pcr is actually not the gold standard without sequencing. There are many false positives. He says he's published a couple of papers dealing with the misconception.
Yeah, the only thing about the genome sequencing, number one, it has to go to a special place to be done. Genome sequencing, I believe here in our area, would have to go to Frankfurt. That usually takes time. So we usually go ahead, if the RT-PCR is positive, then we consider that a positive test. I understand what he's saying. To be completely thorough, yes, you would need genome sequencing, and also to find out if it's a particular variant. It's safe to say, however, because of the prevalence of Omicron, number one, it's definitely going to be Omicron. Number two, that when you're talking about initiating treatment, we really don't have that much time to actually send it off to Frankfurt or, worse yet, the CDC and get genome sequencing back. I do appreciate his statement, but suffice it, and it just may just be the verbiage that's associated. But yeah, it is considered for us when you talk about immediate treatment a gold standard type treatment, a gold standard result.
All right, and I think that's it from the chat area. Does anybody have one last question for Dr. Burns? You can unmute and ask. And also, I just want to thank Jessica Petrie from over at the Kornhauser Library. If you check the chat area, she's linked many of the studies and a lot of the things Dr. Burns has talked about. So you can check those out. There's links in the links from the chat area right now. So
I have one quick question.
Yeah, I'm gonna say it's our last roundup. So go ahead.
This is Swapna there. Excellent talk. Thank you so much. Any idea how and why some unvaccinated folks with the worst prognostic features, hypertension, obesity, diabetes, do get COVID, but do not have the severe version or don't even get hospitalized?
That is a great question. I rarely see that. It is possible. I do rarely see that. It's right now, some of the thinking may be related to their blood type. And again, there hasn't been enough information, haven't been enough studies done. They are actually sort of considered outliers, if you will, because the vast majority of people that have those other comorbidities are unfortunately more than likely going to have a severe outcome.
Thank you. I have a few of these patients, and it's almost impossible to convince them to get vaccinated because they say, well, I've had COVID and I survived.
Yeah, they need to understand a couple of things. True enough, they do generate antibodies, but we don't know if those antibodies protect them against other variations of COVID. In other words, if they got infected with Delta, we don't know that's going to protect them against Omicron. The second thing is those antibodies that they do generate, we don't know how long they're going to last. But it's been shown through studies that if you've been infected, but you get vaccinated and even boosted, you get an abundance, or you get a robust response, antibody response, when they're actually measured. So they actually would, even though they've been infected, if they get vaccinated, they would have a robust response to the vaccine. So I would try and encourage that aspect of it to them.
Thank you.
All right, everybody. I think we've kept Dr. Burns long enough. This is a great, outstanding talk, and we really appreciate it. And as always, it's super, um, super timely and very pertinent, and an update that we all needed to hear. So thank you so much, Dr. Burns. We really do appreciate it, and it was great as always. Thank you so much.
Thank you.
Thank you. And just